Kidneys,
Yes, kidneys, ureters, bladders, and it's named that because those are the structures that should be included on the image. Not necessarily that you'll be able to see those images or those organs on your image, but they need to be included. This is the KUB. It's also known as the AP, the anterior-posterior abdomen. So we'll start with that exam. Have our introductions. Hi, my name is Rebecca. I'm going to be getting an image of your abdomen today. Can you tell me your full name?
Anna Kitzloff.
And your date of birth?
November 11th, 1998.
Thank you. And is there any chance you could be pregnant?
No.
Thank you. I want to make sure that my table is lowered completely for patient safety. Ma'am, if you would, lie on the table on your back with your head on the pillow. I'm going to bring my tube over. Bring my tube over. Getting my tube in transverse detent. That means that my central ray will be centered to my bucky, which in turn means that my central ray will be centered to my image receptor. Now then, I raise the table for my safety. Now there's not a predetermined height that you need to raise the table to. Just raise it so that it's comfortable for you to work and so that you're not having to bend over, bend down to do what you need to do. Our image receptor for the KUB is going to be 14 by 17, so that it's placed lengthwise. And I say lengthwise, that's in relation to our patient. That's the length of the patient, length of the image receptor. When I place my image receptor in the bucky tray, I release this handle, I push it all the way in, and close it to lock my image receptor in the bucky tray. Your image receptor should not be allowed to move freely in the bucky tray. Some people get in a hurry. Come over here. And close the bucky tray with your image receptor still moving around. If you do that, the problem is you're not going to have your image receptor centered to your central ray once you close the bucky tray. You're also not going to get any accurate readouts for your SID collimation size. So we have our image receptor placed correctly. Now then, I'm using my right marker for the KUB. I'm placing that right marker inferiorly to the outside edge of the image receptor, and it's going to indicate that this is her right side. And if you look at the image, you'll see that that marker shows up in the area of the greater trochanter of the femur. Well, yes, the marker is superimposing anatomy, but it's anatomy that is not of interest for an abdominal image, so that's okay. Close my bucky tray firmly. I'm going to bring my tube over. Now, when we were working at the wall bucky, we had to put the tube in detent in 2 dimensions, both transversely, and we had to lock our tube in detent at the appropriate SID. And it was 72 inches for the chest, and remember it was 40 inches for the AP upper airway. We don't have that detent at the table bucky for SID. However, we do have to align, and I want my red laser for this, and I see that it's not on. So there's this white button underneath that slides back and forth. So I want to make sure that laser is on so that I can line up my central ray to my image receptor. I'm going to push the table away a little bit so that I can see that laser. So there's a little red triangle on this image receptor. And I'm lining up the red laser to that little red triangle. Lengthwise, that's the center of the image receptor. So now I know I'm centered to my image receptor transversely, across, and up and down. I close the Bucky tray firmly. And again, to get accurate readouts, you have to have your image receptor seated properly in the Bucky tray. And you have to have that Bucky tray closed firmly. The last thing I set is my SID. And I'm going to look at the readout to achieve that. And my SID is 40 inches. I'm going to press this blue button to raise the tube, and I'm looking at this readout. It says SID 34.6. Raise that some more. Okay. Did you hear that noise as I raised the tube? When I got in a certain range, the tube automatically collimated to the size of the image receptor. So when you're working at the table using the table Bucky, you don't have to go to the control panel to set your automatic collimation like you do when you're at the wall Bucky. So I see the readout here says 14 cross by 17 long. That's what we want. My SID, however, reads 40.2. Okay, so we want 40. So I drop the tube. Now it's at 39.8. What you need to know is on this equipment, you cannot get that SID set precisely at 40.0. So the acceptable readout for your SID when you're working at the table using the table Bucky is either 39.8 or 40.2. Those are acceptable. Now I have my equipment set. My tube is in transverse detent. My central array is aligned to my image receptor. My image receptor is in the Bucky tray properly. The Bucky tray is closed completely, and I have my marker on. From this point forward, all that I do is I position my patient on the table correctly, and then I center correctly. To have my patient on the table correctly means that she is lying in the center of the table. So I should see an equal amount of space from her right hip to the edge of the table as I see from her left hip to the edge of the table. So we need to tell our patient, ma'am, I need you to scoot your whole body just a little bit to the right. There you go. The second part of the positioning is that we need her to be straight on the table, head to toe. We can't have her lying diagonally on the table. I'm just going to move your legs just slightly to your left. Thank you. Now I have my patient positioned where I want her. It's time to center. We're needing to palpate the iliac crest and appreciate that that is lateral. If you're palpating anteriorly and more medially, you're likely to end up centering too low. So you have to palpate for the iliac crest laterally. And this takes practice. You always want to tell your patient what you're going to do before you touch them. Ma'am, I'm just going to feel for a spot on your hip. Now, this ASIS, anterior superior iliac spine, that is anterior, that's the most prominent bone of the hip. So you start there. And then follow that bone superiorly and laterally. Notice when I start to palpate laterally, I'm using the side of my hand. I'm not digging into her abdomen, jabbing her with my fingers. Okay, so that's ASIS. I'm following that bone superiorly. And it's kind of like a shelf. You put the side of your hand into iliac crest. Now, to achieve my centering, I don't move my tube, I don't move my bucky, I move the table. Now I'm centered at the level of the iliac crest. I also need to center at the mid-sagittal plane in midline. So I place the central ray where I believe the mid-sagittal plane to be. Then I come up to the head of the table to verify that I'm centered in midline. And kind of looking at the light, I should see the equal amount of light. So where the edge of the light is on the left to her hip, that space should be the same as the edge of the light on her right to the right hip. Just a teensy bit off center. Okay, by centering at the iliac crest, our goal in this, remember, is to include the kidneys, ureters, and bladder on this image. If I center at the iliac crest, then I should include the entire bladder. Now, an indicator that tells us that the entire bladder is included is when we demonstrate the symphysis pubis on that image. So on a KUB, you have to include the symphysis pubis as evidence that your entire bladder is on that image. It's not that the symphysis pubis is being evaluated, it's just an indicator that you included the bladder. If you included that, you know you've included the bladder. I want you to move your arms a little bit away from your body. Thank you. So you abduct the arm slightly. Shielding is not required. Now I'm going to give my patient breathing instructions. Go over here. Ma'am, please take in a deep breath. Blow it all the way out. Hold it out. Don't breathe exposure. You may breathe and relax. And I believe we talked about this in class on Wednesday as well, why this is taken on expiration. What happens to the diaphragm on expiration?
Moves up.
It moves up. Right, it relaxes. The volume of the lungs decreases, and that diaphragm moves up. Well, that allows you to see more of the abdominal contents, if you will, without the lungs superimposing them. So there's always a reason why we do what we do. So you can kind of see there's a flow. Set up your equipment first. Well, first we had our patient on the table. Then we set up our equipment. Then we positioned our patient. Then we centered. Then we give instructions, make the exposure.
So you said
Ma'am, I want you to just put your hands on the table and move your hands slightly away from your body. Thank you. And this is similar to when you perform the chest. When you're doing your simulation, your patient may stand at the wall bucky with their feet separated already, shoulder width apart. But I need to hear you tell your patient to do that so that I know that you know to do that. The same here with the arms away from the body. Your patient may be lying like that, but I need to hear you verbalize those instructions to your patient.